Good afternoon. On behalf of the Pennsylvania Patient Safety Authority, I'd like to welcome you to this web conference titled Retained Bioburden on Surgical Instruments After Reprocessing. Are we just scraping the surface? My name is Terry Lee Roberts, and I'll be your moderator for this program. Now I'd like to introduce our speaker for the webinar. Jim Davis is board certified in Infection Control Epidemiology, CIC, is a certified healthcare environmental manager, HEM, and holds national certification in adult critical care nursing, CCRN. He is currently a senior infection prevention analyst for the Patient Safety Authority, and Jim is a member of the Association for Professionals in Infection Control and Prevention, APIC, is an APIC fellow, FAPIC, and has served as president of the Philadelphia, Delaware Valley chapter. Mr. Davis is currently the chair of the APIC's National Research Committee. Jim, I now turn the program over to you.
Thanks, Terry Lee, and good afternoon, everyone. Thank you for joining us for this webinar. I'm hoping that you'll find some useful information to take back to your facilities at the conclusion. I do want to apologize for my voice in advance. I do have that cold that's going around, so please forgive my hoarseness. I'd like to cover some objectives first, pretty straightforward and easy objectives. By the end of the presentation, you should be able to recognize the prevalence of retained bioburden on surgical instruments, not only in Pennsylvania, but also have some ideas about how it could be impacting your individual facilities. Describe how the design of the surgical instrument can impact the effectiveness of how it's reprocessed. Identify opportunities for improvement within the reprocessing system at your facility. So first off, we need to do a little background about bioburden and biofilm. Bioburden is essentially the degree of contamination or how much microbial load or how many microorganisms, whether it be macroscopic or microscopic, that contaminate an object. Now, biofilm is different because it's a slime-enclosed community of bacterial colonies that is very difficult to get rid of. In human beings with central line related infections, even powerful antibiotics don't really tend to penetrate those biofilms because they have a crust-like surface. And on instruments, in particular reprocessing, sterilizing systems, because of these matrix of the biofilms, have difficulties if the biofilm is established on penetrating into the deep down layers, so you can still have live organisms left over. Biofilms can also occur on any body surface. Most commonly in a healthy person, it will be on your teeth as dental plaque. Common places in healthcare that we see is definitely on medical equipment. Could be from a central line to a catheter, a Foley catheter, to even equipment used in surgery like heater cooler units that we saw this year with mycobacterium infections, latent mycobacterial infections, because of the heater coolers used in open heart surgery. Contact lenses, if you're not diligent about cleaning and changing, that can also cause issues, and many other places. So it's important to note that biofilms can be visible or microscopic. They can be aquatic, like an industrial environment. So one good example of biofilm is within oil refineries. Biofilms can actually grow on the surfaces between the metal and the oils and thrive in that environment because of their casings that makes them resistant to the oils and the surfactants. And a good example of this, if you ever did any plumbing at home or took apart a piece of pipe and you saw that fouling inside the pipe, that crust inside the pipe, they could be biofilms as well. So, as I said, biofilms can be microscopic as well as macroscopic. Unfortunately, with biofilms, they can develop very rapidly within a few minutes. So everybody originally thought when we were thinking about biofilms it was over days. It's actually over seconds to minutes where they start to set up. So this comes into play when we talk about how are we soaking our instruments, how quickly are we doing it, and then there's also problems with, as we'll talk about later in the slides, about equipment that is left to dry out. So this is the post-launch or during launch ski factor slide. I like to put this in there to show everyone. This is a normal, healthy mouth. If you follow the slides from the top left, to the bottom right, the 3H, 5H, 7H, and so forth, are hours in a healthy mouth. So at the 3H point, top left slide, you see planktonic bacteria, right? So that's just bacteria that's kind of floating around your mouth. So when I say planktonic, it's like plankton. They're just kind of floating around the ocean. So these guys are floating around your mouth. In your bloodstream, they're floating around your bloodstream. So they're kind of looking for a happy home. Now you see in slide 5, a couple of them have gotten together. You see those little arrows in there. They're starting to kind of like join up. By 7 hours, you actually have biofilm formation. So, slide 5, biofilm's getting ready to set up. Slide 7, they're actually pretty much set up. By the time you get to 8 hours, that's complete biofilm. We're starting to form fluid channels and communication pathways. If you go back to the 5H slide, those cells are actually quorum sensing. So what they're saying to each other, and they're communicating, basically chemical communication, chemical electric communications called quorum sensing. They're saying, hey, we found a really cool place to live. We have enough nutrients, we have enough heat, we have enough moisture. Why don't you all come out and visit us? So these cells get together, and by slides 8, 9, and 10, you have fully set up biofilm. In 10, that one shot, you can actually see the biofilm border. It's magnified, and there's little pipe ways in there. They kind of look like coral, because it's kind of what it is. You see little pathways in there where they'll start sending nutrients and fluids deeper down in the biofilm. By the time you get to 11, 12, and 13, you have an established biofilm on your teeth. Now, I'll say it again, this is a healthy, normal mouth. So, worst comes to worst, brush your teeth 2 times a day, so there's the evidence. But the same process can set up on any surface within the human body, and especially artificial surfaces that are implanted in the human body. So I do want to talk about endotoxins just a little bit, because it does come into play. It's not well documented, but we are starting to see more and more literature. So AGIs can be linked to instruments and equipment despite having been processed appropriately, and we see that reported in the literature. But because of the design of the instruments in certain scenarios, which I'll cover, because they prove to be difficult to clean and disinfect or sterilize appropriately. So what we're getting at here is not only do we have a problem, everybody knows with the ERCP scopes and that elevator channel, that pesky elevator channel, where we see bioburden and crust and visible soil sometimes in that channel, but we can also have, because of that difficulty in cleaning, we can have endotoxin build up. So what is endotoxin? It can be present on surgical instruments. It's basically protein, and that can contribute to orthopedic prostheses loosening. We've seen that with not only teeth in dentistry, but we've seen that with hips and knees at some points. So we'll see these things because of not being processed appropriately. The instruments or the implants themselves can have endotoxin on them. Not so much the implants, but more so the instruments, because once blood from a human's been present on an instrument, you do have the potential to have endotoxins there as well. So many adverse outcomes related to the use of poor quality instruments. Essentially, as the cases with the heater cooler units and the mycobacterium, they've gone unrecognized to the tune of 5 years or more, actually. Some of the European cases were about 5 years. So, completely unrecognized until we say, wow, that's kind of a weird organism to be in your chest. And how did that happen? And then we come across the piece of equipment that had biofilm in it. And like I said, some of these things could be immediate or latent. And then immediate could be infection. And then the loosening of the prosthesis may be more latent with the endotoxin buildup. So a lot of risk here that's kind of not thought about too much. But yes, we can definitely have multitude of factors, not only infection-related, but also endotoxin-related. So the next slide here, we're on slide 6, is just a really, really rudimentary example of the types of equipment we're talking about. So this is not an endoscopy lecture, fortunately, because if you're like me, you've had enough of the endoscopes, and we just want a solution at this point. But this is any instrument that you reprocess. So if we look at the Hibbs chisel, man, that's a pretty straightforward piece of equipment. Surfaces are smooth, no nooks and crannies for the most part. So essentially, when you reprocess this, it's very easy to sterilize or clean or reprocess. It's also very easy to take care of from a maintenance perspective, so that's our other issue. It tends not to rust because there's no contact of other metal. It tends to hold the edge because it has a simple edge. It's not a compound edge. It's very easy. It's also very easy to sharpen. So in contrast, we'll take it down to the Pratt hemostat. And I circled some areas on this instrument. So starting where the handle is, you have some teeth there, the locking mechanism. They have indexing teeth, so they have to be brushed and cared for appropriately. We have the hinge in the center where we have metal indexing surfaces with other pieces of metal. There's also nooks and crannies in there. That pin, if it's not cared for appropriately, can rust. So can those intersections of the metal joints if they're not spread out for sterilization or they're not inspected and cared for. And then at the operating tip there where it's meant to the compressed vessels, there's also some teeth in there depending on the type of the proud hemostat that also would need brushing and care, plus cleaning out the tube sections there. So again, two very, very common, very simple surgical instruments. One example is pretty easy. Second example could be a nightmare if you're not in tune with looking for what we're talking about today during this webinar. So from the authority perspective, we always try and tie it into, we've heard reports with some news stories coming out locally, plus a lot of coverage in Detroit around reprocessing. So we decided to take a look at the database, and we cleared it from January 1st, 2005 to December 31st, 2015. Pretty large date range there. Fortunately, we have a robust database. Why we stopped at 2015 at the time that the article was written, that these slides are based off of, that was the most full set of data we had up until that full year. So how we did it, we compared the trend we found in PA Pacers data with some PHE4 data, the Healthcare Cost Containment Council data, and we looked at acute care procedural denominator data, so how many procedures were done. In Pacers, we just looked at the overall number of reports, but we wanted to actually account for artifact within the Pacers data and externally validate our data against what procedural data looked like. The other advantage of PA Pacers is the event reports include free text narratives that folks who report this type of event, a rusty instrument, a case tray that had a hole in the drape, or filters weren't missing in the tray, or what have you, they can not only fill that in as a report, but augment that data with a narrative, their own words, which also helps us identify trends more from a qualitative perspective. We also compare reports to the narratives, and we looked at this specifically to pull out some recurrent themes. The goal there being is we can present to you, our customers, we can present to you this data, and you go, okay, well, what do I do with it? If we can identify recurrent themes, that could actually give us some information to give back to you as far as where you can look, make differences in your facility, which I think is more important than the data itself for us to be able to help you look at these types of incidents in your facility. We took it a little bit of a step further because I wanted some real-world data, so actually found 6 individual operating room clinicians from 4 hospitals in different regions in Pennsylvania. The interviewees, we informed them that we had received these reports, not necessarily from their hospitals, concerning bioburden, debris, and lack of quality reprocessing. We asked them to describe some of the rationales and explanations for what they believed. Now, these were experts in the field, what they believed to have contributed to the events. And the interviewees actually said to us that they've experienced pretty much everything that we described to them. So that was actually more validation that we did have an issue. These interviewees agreed to speak with us because of our strict confidentiality rules. You'll never know their names or their facilities. So if you hear something mentioned in this PowerPoint that you think could be you, chances are it was not you. And we would never tell anybody that it would be any hospital. So I just wanted to maintain that confidentiality. So here's some of the results we have. These are the quantitative results, essentially the numbers. So if you look on the left chart there, the event type is how they're classified within the PACER system. So you can see that covers pretty much the gamuts, J, F, E, and C. So multiple categories folks report these incidents into. And then you can see the overall number of reports has been increasing since 2005. And like I said, these are raw numbers of reports. So not really, without really a denominator, we were looking to how can we validate this and see that it's a true rate. And that's where the bar chart on the right comes in with the rate per 1,000 inpatient claim records. So the denominator here is actually the number of inpatient claim records that would equal procedures. So as you can see, although the numbers are different, it's eerily similar to the chart on the left. So this is actually validating the fact that it is true that these events with reprocessing have been increasing over the years. So again, it's very important for us to be able to draw attention to this as a call for action. So some qualitative examples from the report narratives, which I think is important for everyone to hear. So we had one where there was loaner instruments that were ran through the washer decontaminator and then wrapped and run through the sterilizer. Pretty much standard procedure. But, however, during the setup for the case, there was dry blood on the set. So were these instruments properly, cleaned with an enzymatic, or was it an instrument type that could have been done with an ultrasonic cleaner before the washer decontaminator, or, so how many steps were actually missing? This one, they were pushing bone graft into the instrument, and dry tissue from a previous case came out into the field. So that's, I don't know about you, but that's not very good for an OR team to have to stop because of something like this. It's frustrating to the OR team, the surgeon, or the other participants. I'd be upset if this happened. Maybe I'd be a little distracted, and now I have to do a case questioning the quality of my instruments, although this was broken down and reset. But you put that doubt in your mind about the system. So, yeah, I don't know. I wouldn't want a distracted surgeon or a mad surgeon working on me. So there's more to it than just contaminated equipment, not to mention you're delaying a case. And then you're putting a patient under for a longer period of time. Third bullet point was some debris from a prior procedure dislodged from an endoscope, floated into the ventricle. So this was a neuro case. They couldn't retrieve it. And so, what do you do at that point? You floss the ventricle and place the patient on antibiotics and hope for the best. We don't know if this was close to the patient. We would encourage disclosure. Transparency is always better than not. But again, not a good situation to happen to the patient, let alone the operating team. On the next slide, slide 12, you'll see there was a laminectomy performed on a local bone graft. The staff noticed that the sterilized instrument pan containing spinal instruments was contaminated with blood and tissue from another case. Of course, the case was delayed. So we don't have any information about the outcome, but we're assuming that they broke it down and started over. Again, delaying a case, inconveniencing a surgical team, and hopefully they're looking at their system at this point. Excuse me. The fragments of bone cement were observed in the patient's knee, but the surgeon hadn't used cement. So, where did it come from? The scrub nurse noticed that the instrument impactor in the set had cement from a previous case. So they changed the wound class from 1 to 2, which I guess is appropriate at that point, but I'm hoping they followed up with the patient as far as disclosure, maybe some prophylactic antibiotics, and close follow-up. So, we don't know. We only have limited information with the narratives, but we're hoping folks to do the right thing. But we're also hoping through this type of information, when we deliver it out to you guys, that you'll start looking at your reports and start interviewing staff, looking at these narratives, and then looking at your overall system. So as far as the interview results, this was the third step we took just to get a little more information around the problem and come up with some areas of focus. So the interviewees disclosed to us that reprocessing staff patterns don't necessarily align with increases in surgical caseloads. So staffing patterns meaning that you may do all your cases between 7 and noon or 7 and 2, and then you're scheduling your reprocessing staff to come in, at 1 or noon. So they already walk into this unrealistic buildup of trays waiting to be reprocessed, and then they rush through things and maybe take some shortcuts. There's also some unrealistic expectations related to reprocessing production pressure. Again, we had interviewees tell us that the OR was calling down, essentially demanding the tray back that they just sent. And that, for me, is a lack of equipment. So there's no excuse for not having enough equipment to keep up with your demand and turnaround times. This happens to be specialized equipment or physician preference or team preference. So again, unrealistic expectations. And some folks didn't even know how long that were calling for a tray, didn't know how long it would take to even reprocess it. So it could take a few hours for a certain piece of equipment versus what they thought should take 15 minutes. Again, I mentioned the subpar levels of surgical instrument stock. We see this when flashing or IUSS, immediate use sterilization, was unfortunately in vogue. People got around subpar levels by flashing the instruments. We saw huge problems with that as far as quality and effectiveness and cleanliness. So that process, if you're doing it, should be halted. That's strictly for emergencies, not as an excuse to augment your surgical stock. So if you need more, you're going to have to purchase it. Reprocessors' unfamiliarity with the manufacturer's instructions for use, or IFUs. So they didn't know actually how to care for the instruments. We had the whisper down the lane. Well, Betty told me back 15 years ago when she trained me that this is how we did it. And no one actually had access to the instructions for use of the IFUs. This is something that all facilities should, with reprocessing staff and reprocessing programs, should have the IFUs available. There's also some pretty nifty web-based portals now that have all the IFUs stocked that the reprocessor can just pull up very quickly with a search to see what exact instructions. This comes into play not only with new staff but old staff as far as training and competencies, but very, very important when you have a new piece of equipment that could be a scope and the folks are looking at it like it's just another scope, but it might have special portals or special brushes or special caps. So again, the IFUs should be very, very handy, and your folks should know how to get to them. We've also seen the operating room staff not consistently wiping, pre-cleaning, or soaking the instruments prior to sending for reprocessing. And this is, as I currently have a teenage daughter and an 11-year-old son, I call it the dishwasher syndrome. So they don't get many jobs, but I do tell them that they're responsible for cleaning up after dinner. And they're always in a hurry, so they throw everything in the dishwasher with all the food still on it. And then they start the dishwasher and you get the cycle going. Then you pull it out, and you need a chisel and a hammer to get the lasagna off the plates. This is the same exact problem. So without wiping the instruments off, soaking in the enzymatic, keeping them moist or wet even, and then getting them as quickly as you can down the reprocessing, it keeps that bioburden soft. It dissolves the blood and the protein and whatever endotoxins could be lingering in there, and makes it easier. You're setting up the reprocessing staff for success. And furthermore, it doesn't have to happen when the case is finished. I mean, I know of several facilities now, both in PA and other places, that are starting this process at the point of use. So as soon as they're done with the equipment, it at least gets wiped off and maybe placed in some enzymatic while you're still in the room. So that's pretty aggressive, so you have to work that out for yourselves, but definitely something to consider to make the job of reprocessing easier and more effective. We saw some surgical instrument trays sitting for prolonged periods of time before being sent for reprocessing. And I mean prolonged periods of time. I'm talking hours. So folks are calling down the central sterile saying, where is it, where is it, where is it? Or it's still up in the OR, and it's dried out. So it's making things harder on everyone. So there should be a process to get these things to where they need to be quickly and safely. So you need to look at your covers and things like that if you don't have elevators. The operating room reprocessing department is treated as separate teams. This was a huge, consistent message that we got through the interviewees. There was a lack of cohesiveness between departments. I hate the word silo, but they were functioning in silos. So, the OR didn't have appreciation for the central processing team and their work. The central processing team didn't really understand or have an appreciation of what happened up in the OR. Now, once we got these teams working together, as reported by some of the interviewees, once these teams started working together, everything got a lot smoother. The OR teams understood why they needed to soak and pre-clean the central reprocessing staff, because they were getting things things were a little easier as far as cleaning because of the soaking, and the trays were coming down right away, could manage the turnaround times more effectively, and they respected each other's staffing patterns, and staffing patterns were adjusted. So again, mission critical tasks here. The OR can't function without central sterile. Central sterile wouldn't have a job without the OR. So again, these teams need to be combined and cohesive. I love it when the same manager manages both teams. However that's set up in your institution, it seems to vary widely. There's a lack of standardized training and education, not only for the CSR staff, but also for the OR staff that are responsible for these instruments until they get the CSR. And it should be joint training, so when the topics align, that it's appropriate for joint training. But standardization, annual competencies, or more frequent if necessary, and especially when you get new equipment in. Again, poor workflow design in the reprocessing department themselves. So are you set up that you're cleaning all the hospital equipment, or are you set up that you're cleaning only the OR equipment? Are you taking in equipment from other areas? Do you have ambulatory surgical centers that are sending you stuff, which is unfortunately very common? So how does your workflow work with all the stuff that you need to get in and get reprocessed? So that's a whole project to be looking at that workflow. And inconsistent auditing of process measures and quality indicators. There were some facilities we spoke to that didn't do any line picking, which is kind of scary, because they didn't want to have to break it down and reprocess it again. That's just the price you have to pay for quality. And you should also be surveying. Don't wait for the reports. You should also be getting information from your surgical teams, from your OR teams, and from your CSR teams about, a simple questionnaire maybe once a month or once every few months about how are the processes going and how are they working. Some of your best suggestions are to come from the grassroots or at the pointy end of care. So as far as discussion points, high quality reprocessing surgical instruments and equipment, it's mission critical. You can't proceed safely without this equipment being processed appropriately. It is a team job. It's the operating room and CSR working together. The operating room and its basis depend on that reprocessing department. Without them, you can't do your job. It's that simple. You need a good quality and adequate flow of surgical instruments and equipment to perform the patient care and the life-saving that happens. So again, cohesiveness of teams, identification of improvements in your system, and respect for workflows in each department. So we looked at some themes identified in this presentation. The efforts can be considered to unify departments. We've seen great success with departmental activities, like maybe it's a holiday party including CSR, and some of the OR teams didn't even think about including CSR until we mentioned it, or central sterile, excuse me. So, again, team building, looking at processes around the care and the maintenance of the mission critical items such as surgical instruments, devices, and other equipment is crucial, and eliminate some of the issues that we see with that were highlighted here. Reprocessing and operating room staff need to have access to each instrument's IFUs or instructions for use. That they are how you clean, care, disinfect, sterilize, and maintain this equipment from the manufacturer. You should not be home-growing policies to be caring for equipment. You should also not be looking at or purchasing equipment that does not have adequate IFUs attached to it. So again, when it comes to purchasing equipment, it should be a team decision from the surgeons to the nurse managers, to the OR staff, to the CSR staff. A lot of times the purchase is made because somebody likes the equipment or somebody feels that it can make their technique better, but then it gets to CSR and they have no idea how to clean it, how to use it, or mistake it as just being another pair of scissors or another type of scope with the same IFU of the 9 other ones they have that might be a little bit different. So again, very, very, very important to know what's going on. As noted in the results, there have been many reports of debris lodged on and inside instruments. High-risk instruments are those with the gaps, the lumens, and the channels. I've seen brushes augmented from other things, like, you go to Home Depot and you get one of those kitchen brushes. They're cleaning out of glass. I've seen those. I've seen equipment-specific brushes, especially for scopes and lumen instruments or things with gaps and channels, where they've been used so much that the bristles are essentially gone. And the CSR staff thought that because it was equipment-specific that it was expensive. So they were trying to use it for as long as they can versus throwing it out after every other cleaning. So again, you need to be looking for these things because if you're not in that department looking around, you'll never know. Once the debris dries inside of an instrument surface, the instrument becomes increasingly difficult to clean, especially with lumens and a worn-out brush. But if you're not pre-soaking this stuff, it just builds up, and then you have biofilm formation and bad things happen, and especially if it fragments off. So when cleaning starts at the point of use that I mentioned in the operating room, removing debris at the point of reprocessing becomes more effective. This is actually one of the easiest interventions you can do is look at your system and figure out when they get wet and when they get their enzymatic applied to them. And if you can move that as close to the end of use of that instrument as possible, it really is effective at making everyone's job easier. So, equipment design, that also plays a vital role in determining how easy and effective the reprocessing methods can be accomplished. So when you're purchasing equipment, if a more simple piece of equipment is available that does the same job, you should be looking at that. If it has extra bells and whistles that you don't really need, the question becomes, do you really need them? So when purchasing equipment, look at that design and the entire use cycle. So is it easy to reprocess? Do they have a good IFU? Is there specialized tools for cleaning? And then look at that reuse cycle. Critically important to your processing decisions and your purchasing decisions. And if reprocessing staff point out that the design of a device is problematic from their perspective, it may warrant, like I said before, looking at a different piece of equipment. So you need to bring the CSR folks into the purchasing pathway. So if there's a purchasing committee where the surgeon or the physician might be on with hopefully an infection control person plus the purchasing people, those folks should recognize that if it's a surgical piece of equipment or a medical device that's going to be reprocessed by them, that they need to be at the table. Nothing about them without them, and that goes for everybody. If there's no other alternatives, then you need to look at the instructions and how to process the device, and that's another conversation. Do you have do you have the equipment to actually process this, and do you have the training behind it? So in conclusion, we presented a lot of data here. We feel it, from a sort of jocular perspective that we're just scraping the surface here on a multitude of factors that affect the critical task of reprocessing. Qualitative, quantitative, and expert interview data are compiled for you, so you have an idea now. So now that you're informed, you're responsible. So hopefully you'll be able to look at your systems and look at patient outcomes in your processes that affect not only outcomes but satisfaction, staff satisfaction, patient satisfaction, workflow, finance, and other variables. And the data and concepts herein were intended to give you guys a starting point for self-assessment of the entire reprocessing continuum. That is from the end of the case to the beginning of the next case, to make sure that everything is inclusive of all users, departments, because everyone interacts with the surgical instruments and equipment, and you need to be able to find quality improvement opportunities that you can apply for the safe reprocessing of these types of instruments. So we do have a patient safety impact assessment tool. This is geared for any equipment. So not specifically geared to OR equipment, but we've provided this document and the links to the document. And essentially what this does is it looks at the equipment from a people perspective, from an equipment perspective, and then from a process perspective. And what this, it's a fillable form that allows you, when you go to your purchasing committee meetings, or if you're individually evaluating a piece of equipment, it walks you through some very important environmental and human factors questions, and will also, if it's a larger piece of equipment or another design process, can also point you towards the NASA task load index when if the piece of equipment or process is actually adding folks or increasing their job responsibilities. So it can point you to another assessment to wrap your head around what the task load looks like for folks in your system. So again, not specifically designed for surgical instruments, however, definitely designed for looking at how any equipment from surgical instruments to CAT scanners affect the people and environment in your charge. I'll turn it back to Terry Lee here for any questions that you guys may have.
Thank you, Jim. You certainly provided everyone with valuable information that they can take back to their organizations. Okay, Jim, the first one, we've been hearing that it will be a standard for staff to be certified in sterile processing this year. First of all, is that correct? And if so, do you know if all staff will need to be certified, or if you could just have one staff member certified and they can train other staff?
That's a great question. So, the first challenge I'll put out there is, why are we waiting for regulatory bodies to tell us that it's a requirement? Anybody that's touching surgical instruments and reprocessing should be seeking certification from their professional organizations. And so that being said, that yes, there is legislation that I'm aware of currently on the table that will be specifying that reprocessing folks need that certification, but my challenge is, why wait? And the answer to the other question, could you have one? From a litigation standpoint, from a liability standpoint, if I was running a program, anybody that was responsible for reprocessing would be at least certified, or in their job description within a training period and a clinical period. That would be a job requirement for me.
Thank you. And the next question, does using enzymatic cleaner in an ultrasonic cleaner increase the risk of TAS in ophthalmology?
Well, toxic anterior segment system. So, you would have, that's a great question. It's very difficult because you need to look at your ultrasonic reprocessor. You need to look at the instructions for use for that to see if they specify a certain type of enzymatic. Then you also have to look at the enzymatic you're currently using to see if it's compatible with your ultrasonic equipment. So again, I'd be looking at those two factors to see if what you're currently doing is safe outside of TAS in general, just safe and recommended by each manufacturer. And as far as toxic anterior segments, I'm not familiar with any literature that I've read that specifies a decreased risk.
Okay, thank you. The next question is, where do the participants find in PACERS where to enter that there were bad instruments due to torn wraps, etc.?
So, in the PACERS report itself, you can essentially pick where you feel that it aligns, but in the narrative section, there was a narrative section where you can specify in free text what happened. And as you can see, that when you guys take that effort to fill that out, we do look at it. It doesn't go into a black hole. So, it would be in the narrative section or the free text section. I believe it's at the bottom of the document off the top of my head.
And the next question, when cleaning a lumen, can you take the brush back and forth, or should the brush just go in one way, just one direction and pulled out?
So I won't make a One Direction reference. So, that's my daughter's band, right? So, that is a specific question that needs to be addressed in the IFU of the equipment. So some equipment is designed for you to brush both ways, essentially like a gun barrel. But other equipment, depending on the brush design and the lumen design, may only require you to go, from distal to proximal. So that is something that you need to look at the IFU for, depending on the equipment type. And if that's not answered in the IFU, you need to contact the manufacturer. And that is a very good point. So when you contact that manufacturer, you need to get from them documentation that you'll now store with your IFU, that you've asked the question how to clean it as far as this brush movement, right? Sometimes they don't include that in the IFU. It's a very good question. Get that documentation, put it in with the IFU, and store it. If you ever get challenged on it, you have the documentation from the manufacturer. A great question.
Thank you. Jim, what would be an example of how one would check the quality of reprocessing before the instruments get back to the OR suite?
So we're going to go back to basic, basic Deming and, total quality management. There's similarities, although, our work may be more technical, the instruments may be more precise. But there's no difference between reprocessing quality checks and if you were making brake pads at Sandusky Motors. So what industry does is they pull lots. So at the end of at least every day or more often, go pull a tray that's been reprocessed. Take it apart. Look at every piece of equipment. Take out your magnifiers. That's another good point. When these folks are reprocessing the equipment, are there magnifiers? First of all, do the lights work? Are they pulled out in front like they're using them, or are they pushed all the way back behind the computer monitors? So magnification is huge from a quality perspective in general, but as a manager or someone responsible for quality, go pull a tray. Go pull a tray once a day. And then once they know you're looking, things will get better. Then you can go down to pulling a tray maybe once a week, as long as you're comfortable and you're getting few reports. So again, look at your reports, but be proactive. Don't be reactive, because your reports are reactive. Look at your trays. Take them apart. Look for holes. Look for rust. Look for dull edges. Look for bioburden. Run a brush through a channel. See if you get anything. That's the type of things you have to do. And then that's an auditing process. And with auditing goes feedback to the staff. So bring your findings back, because what you're going to find there is maybe they don't have the right equipment, or the brush is worn out, or there's a discrepancy between your policy and the IFU. So again, great question, and that's some things to think about.
Okay, Jim, in your experience, is there a commonly missed step when instruments are reprocessed?
Well, going back to magnification, I find that, like I said, their magnifiers are pushed back against the wall, and they're not being used. Magnification, I just got glasses this year, and I think I need new ones. So if I can't read a document, how are we looking for little black specks on shiny metal without magnification? And then the other step would be getting that enzymatic cleaner and those instruments wiped off, and getting that enzymatic on the instruments as close to the end of use as possible.
Jim, I have a question here in regards to pre-cleaning. Do you know if there's a difference between gel versus foam spray?
For the enzymatic, I'm assuming is the question. There's different theories about that. It depends. Again, when you look at your instruments, if you're looking at the enzymatics, I know folks who like the gel because the gel adheres more. However, depending on the product you're using, we've seen some gel get stuck in hinges and things if the gel is left to dry out. So again, the foams seem to stay more aqueous longer, but if you have a quick turnaround time and you're looking for something that's going to stick to the instruments and they're not sitting around drying out, either one could be as good. But that's something that you have to investigate for yourself depending on the product you're using and what you're using it on.
Okay, Jim, going back to where we discussed the current legislative proposal for certification, I have a participant asking, would that also apply to office practice settings?
So office practices, I'm going to interpret as maybe ASCs or endoscopy suites, or maybe someone who's doing procedures in a GP's office. So, if you're reprocessing instruments, whether using high-level disinfection or you have a tabletop steam autoclave, again, from a legal and liability perspective and a safety and quality perspective, if someone's operating that machinery, technically they're reprocessing, so the answer will be yes.
Okay.
And even if to clarify that real quick, even if the legislation specifies who, you're reprocessing equipment, so it makes sense to have your staff trained and certified. It just adds more quality, and it's not cost prohibitive.
Agreed. Another question, is there a problem with using a needle or sharp instrument to chip out bone chips out of instruments?
Well, That's probably not in the IFU, and it's also an OSHA risk. So, I don't know if I can encourage that behavior if it's not covered in the IFU. And if it is covered in the IFU, it's still a dangerous practice for many reasons. And if you're using a sharp instrument against a surgical instrument that's polished, you're probably creating scratches in that instrument. And those scratches leads to valleys, which leads to moisture collection, which leads to microscopic rust, and then gross rust. So you're not doing your equipment any favors. But I'd examine my IFU because that seems to me like it's a homegrown process.
Next question, what is best practice when you have trays of instruments with different IFUs? Some companies are extending cycles. Does this factor in, and should we look to separate these instruments altogether?
You need to comply with the IFU, and it's unfortunate because I feel your pain. Yeah, you need to look at the IFU, and you do need to follow the IFU regardless of how many different processes you have, which is another lesson. So when you're looking at your combinations of equipment and your combinations of trays, you should try to standardize as much as possible. Because sooner or later, if you have all different things, you'll be chasing rabbits.
Next question is, do you have any suggestions on how you could increase compliance at the point of use with pre-treatment of instruments?
Audit. Let them know you're looking.
Very good. And the last question that I have for right now, are there any plans for a future program on instrument reprocessing in a physician's office? And will medical assistants need to be certified in the future to reprocess instruments in the office? And I think you've already covered this somewhat.
Yeah, we covered the certification piece. What was the first part of that question, sorry?
Are there any plans for a future program on instrument reprocessing in a physician's office?
I'm sure we can look at that in more detail. I'm not sure how many reports we get, but the issues with reprocessing tend to stay the same, although volumes in physician offices may be lower and easier to manage depending on what they're doing. But you haven't really looked at that yet, but definitely worth looking at.
And we do have one more question, Jim. Would it be a good idea to soak instruments in sterile water during longer cases to help reduce the bioburden before the enzymatic cleaner can be used, as long as the instruments can be soaked in sterile water?
If it's okay with the manufacturers, I know folks that are doing that. I would stay away from, and I'm glad you're saying sterile water, because you want to stay away from the salines or anything that might be caustic and ruin the surface. I would be, however, very cautious about how long that is. So if it's something that you can maybe, and I'm not advocating OR traffic, but if you're doing an extended case and things are piling up, is there a way to get that stuff out of the room? If you're doing a case that's an hour, probably not an issue. So again, stay away from over soaking because it is metal, although it's stainless. Quality can be depending on where you're getting your instruments. But saline and those things will cause rust and other issues with corrosion. And once you have pitting on an instrument, it's not good from a reprocessing perspective. But we've seen folks doing that, but doing that smartly.
Thank you. And we do have time for one more question. What is your stance on having brushes and alcohol for flushing on the clean side for the purpose of checking cleanliness of instruments after they have been washed?
Again, that's a hard question to answer in a webinar because I have to see exactly what instruments you're referring to. I'm assuming because you're using brushing and flushing, you're talking about lumens. I would make sure that all reprocessing is done on the reprocessing side for many issues, and that would almost be a reprocessing step, although it's a last chance quality check. There's a lot of different environmental controls that we don't think about in the processing side versus a clean side. We're talking about positive and negative pressures and ventilation and things like that. And since we're using alcohols and brushing, they're going to be aerosolizing chemicals. So, I would keep that, in my opinion, I would keep that on the reprocessing side as a last step measure, as long as it's okay in the IFUs for whatever equipment you're doing that to. So as far as alcohol and degradation of surfaces and things like that. So I'd look at the IFUs and see if it's acceptable. If it's not in the IFU, pose it to the manufacturer, but I would keep that process on the reprocessing side.
Thank you, Jim. This was a great presentation. This concludes our webinar.